All right, folks, I think we're gonna go ahead and get started. Thank you all for being here or online. So today we have one of our own, Rashad Massoud. He's a visiting faculty here in the department. And I guess this is gonna be a mix of things you've done, but focusing on improving healthcare. So floor is yours.
So my name is Rashad. I'm an MPH class of 93 here. I'm a physician by background, and I'm a former president of the Chan Alumni Association, and currently I serve as an appointed director to the university-wide Harvard Board of Directors of the Harvard Alumni Association. So long-term involvement with the school in different ways, and I've also been coming here to teach other classes at the same time. Marcia, thank you very much for inviting me to share some of the work that I have done. The focus of my work has been in what I call improving healthcare, making healthcare better. And sometimes that requires some explanation. So what is it that I basically do? If I break it up into...
Did you move the slides? Because we're still seeing them.
It's not moving.
The keyboard?
Touch the screen. Keyboard.
There.
Oh, no.
Oh,
So
too
too
far.
much.
I clicked on it, but now it works with your keyboard, I think.
Okay, super. Thank you. So if I break up the work that I do, usually I get asked to help a country, a health system, to solve a problem that they have. And normally the types of things that I get asked to do are things like, we have a very high neonatal mortality rate, a high maternal mortality rate. Can you help us reduce that? The majority of the work is sort of like patient-related and big ticket items that they would bring us to work with them on. At times, and I have one coming up right now in March, the country of Belize, we've been working with for many years. It's been a while since I've last worked with them. We helped them set up an improvement infrastructure to reduce maternal and neonatal and childhood mortality. And now they've come and asked, well, it's going very well with MCH. However, we're not able to move it to other parts of the system, and could you help us do that? So you get all sorts of requests like these. Now, this is it's less of a technical exercise and more of a leadership engagement and strategy exercise. But of course, they do weave in technical updates and other things as part of that assignment. And I'm looking forward to that very much. It's been a number of years since I've last been here. Then once we have something that works and they get the results and they're happy with them, the next question that comes up all the time is, how can we take this to the whole country? That is, how can we scale up something that has actually worked? Now within that, there's always, within the work that I do, there's always two sort of things that are front and center for me. The first one is, we're not consultants, we're in the arena of global health development. And what we're trying to do is really enable local structures to be able to do this. So the first thing that we're looking at is how sustainable is what we're trying to do. And the second thing is, are we able, through the process of working with them, to develop the capacity for them to be able to do this independent of us going into the future? With those types of things, then the usual question that comes up later is, well, how can we make this integral to the system? How can we make sure that it's happening everywhere? And that leads us into another area that we've heavily engaged in, which is national quality policies and structures for improvement. So working on a national policy level, as well as creating that infrastructure, the human infrastructure in particular, that's able to make improvements happen on a regular basis. So you can see there's a logical sequence: improvement, scale up, sustainability, including the capacity building component, and then the structures and human capabilities for national quality level. Each one of these topics is worthy of more than one session in its own right. Today I'm going to focus on the first part, which is where everything starts, the improvement itself. But of course I wanted to link it up to a bigger picture of generally, when I say improvement, I'm not talking about only the beginning part, I'm talking about all the other components that normally are associated with it or follow it.
It's not changing. Are you changing?
Yes. Now, as we discuss things towards the end, I'm also happy to answer any questions you have related to scale-up, sustainability, capacity building, national policies and structures, and others. Before I sort of go further, I'd like to talk about what are some of the key concepts that underlie the sort of work that I do and my colleagues in the field. The first one is that the fundamental concept is that every system is perfectly designed to achieve exactly the results it achieves. If we continue to do what we're doing, we will continue to get the results that we're getting. If we want to get different results, better results, then we need to do something different, something that allows us to get those results. At the heart of our work is change. Unfortunately, not every change is an improvement, and some changes may not yield improvement. Other changes may actually make things worse. So the only way we're going to tell is if we actually measure what we're doing and the effect of what we're doing. That's the first one. The second is all the work that we're doing is really there to benefit patients. And so it's all focused on the patient's needs, whether even when the minister requests it, they request it because the patients need it. Key to our work is the idea that everything that we do in healthcare delivery, just like we do in everyday life, can be expressed in terms of processes and systems. Processes are the sequences of steps, the things that we do that convert inputs from suppliers to outputs or outcomes for the beneficiaries, the patients, the system that we're working with. And the system is basically the sum total of all of the processes that come together to produce one common result. The third idea is that we don't do the work for them. It is when we do this work, we basically engage teams of healthcare providers and patients who are involved in this process to develop solutions, test these solutions, implement these solutions. They're the ones who collect the data, they're the ones who look at this. And this goes very far into two items. One is capacity building and the other one is ownership. This work is theirs and therefore they own it. And that's really important. And then, of course, critical to all of this is testing and measuring the effects of the tests of different changes to yield the improvement. Several years ago, I added shared learning because I did start an improvement when we used to work with individual teams. Today, I would not design something that had individual teams. I would always work with groups, multiple teams that are all focused on the same thing, and I would create that learning process between them. It needs many more tests of change are being conducted, things are faster, and actually we get better results when we do it this way. So with those sort of, I just did a very high level sort of like what are the key things in improving healthcare. Let me go into one example. I chose an example that we've just, it was the last thing that I worked on at AmeriCare's India Foundation. Basically, we worked on improving care for patients with hypertension. They have a significant number of patients who have hypertension. Part of our strategy was not just improve care, but also to address any inequities in healthcare. And so that was really important. So when we start to work, we say, what is it that we want to improve? How will we know we've made the improvement? The indicator that we decided to measure was blood pressure control, proportion of patients whose blood pressure is controlled. And then in order to address health inequity, what we wanted to do is look for inequities, deliberately seek any inequities that exist. And so we stratified by age, stratified blood pressure control by age, by religion, by gender, and by geography. We only found one, which is a gender inequity, where males are not doing as well as the females. And this is a common pattern that we've seen pretty much in many other places. The setting I'm talking about are 8 mobile health centers. These are like ambulances equipped as health centers that travel to the sites. They serve the slums around Mumbai, in Mumbai city, India. All 8 of them have about 62,000 patients in their registry, and the number of patients who are involved in this work were 6,515 patients. And if I can share with you, this is the result of the work. This is a time series chart, basically percent patients with controlled blood pressure on the y-axis, the time on the x-axis, and as you can see, the black line is the total, so this is for all patients. The red line is for female patients. The blue line is for male patients. Now, as we started the work, the second lockdown, COVID lockdown in India took place, and also coincided with the Diwali festival. And then, so we started the work, but it didn't really show much improvement. And then the lockdown came and things sort of really stagnated a little bit. After that, we can see a little bit of an improvement. And then the third lockdown happened. And after that, we can see a significant sort of change in the results, and the improvement started to pick up. Overall, blood pressure control was improved from 61 to 91%, and gender inequity was reduced from 11.4% to 2.2%. So those are the results for all 8 mobile health centers combined. I took one of them, just one mobile health center, because this is where we get to see the changes that were being tested and implemented. I'm not going to go through it all, but as you can see, one of the principles that we go for is we test one change at a time to see if it had effect or not. The ones that are in green are the tests that seem to work. The ones that are in brown are the ones that did not seem to work. And as you can see, multiple different changes in the care delivery. So it's not really about a science of how you manage hypertension patients as much as that is a given. It's more about how you deliver care to enable the implementation of what we know to work for every patient every time. And as you can see, the result is also similar to what we had before in terms of the improvements. Now, the way in which statistical significance here is achieved in this one and also in the graph before is that this is the median line, and in when you have sequential data with for the same cohort, same patients, this is the total patient population here. If you get what's called a run of like 6 or more data points above or below the median, that indicates a significant change. And of course, we're making the changes, we're testing changes, and able to see that this is making sense in terms of the results. Now, this here is basically all of the mobile health centers. You can see them on the top. They go by the zodiac signs. And the different changes that were tested, the ones that are in green are those that worked, and the ones that are in red are those that didn't work. And as you can see, there's like a spread of, some changes seem to work better than others, some less so, but pretty much, a phenomenon that we see in improvement all the time, which is it is contextual. Context is king. In some places this works, in some places something else works, and one thing that works in a lot of places may not work in one place or two, etc., etc. But that's generally the type of work that we do. Let me pause here for a minute, get any comments or questions before I go on to the next part.
I have a quick one,
Please.
if you can go back one slide. What was the median? Because I can't read the Excel.
There was 70-something percent.
Okay, and that's the percentage of patients that go to a clinic that
The-
have normal blood pressure. Is that what it is?
Whose blood pressure is controlled. So these are hypertensive patients.
They are hypertension and it's control. Okay, and the gap you're reducing is the gap. Okay, males and females. I got it. Okay.
So the gender gap is,
Okay.
there's a difference between the blood pressure control in females and males. And there are good reasons for that. Males generally don't show up as much. They are away at work. Sometimes they don't come back for a week, etc., etc. So testing different changes.
It's interesting that you don't have a geography gap, considering the next slide, that interventions are like, there's not a single one that fails everywhere or succeeds everywhere. So it's surprising you don't have a geography gap.
So this is not unusual because, again, we're not testing efficacy. We're
No.
testing things that are established to be efficacious and how we make them work in real life situations. So they're interacting with the context, and the context is different in different places. And so what works in one place may or may not work.
Are you able to see any patterns this in the next slide where you've got that variation?
So if you look at, so for example, community health volunteer support, and there's this or something like that, I don't know the Indian word, that seems to be, all that work, except for in Pisces it didn't work. But other than that, it worked.
Yes, sorry, I may have missed it. So there's 12 mobile clinics, mobile
8.
health centers. How many people do they serve each one?
So 8 mobile health centers. They serve a population of 62,000 patients. Of that population, 6,515 have hypertension, are diagnosed to have hypertension. Unique patients, please.
My first question is, how do you evaluate if these things work or not work? And second, do you offer all of them and throughout the time just adapt to what works and what not? Or how is the usual approach?
It's a great question. So 8 started at the same time, worked at the same time, tested different changes. And this is like an aggregation of what worked, what didn't work across the mobile health centers. We did bring them together so that there's an exchange of experiences. So all of them got to test, most of the changes that were being proposed. So that was one. How do we basically say to them, so these are the teams and they're at liberty to test what they would like to test at different times. So one of them will be testing, for example, the phone reminder at the beginning, one of them might be testing it towards the end. We don't tell them, we don't tell them what to do, and especially in this case, we're not doing that. However, now that we have this, if we were to start another improvement project of a similar nature, we would say, your colleagues in India did this, and this is what they found. So it gives them something to go off, but it doesn't mean that any of these will necessarily work in a new context. I'm sure some of them will, but so we're not dictating the changes. Again, these are not changes in the science; they're changes in the delivery of the science.
I think she also asked if they overlapped. Didn't you ask this?
Yeah, I was just wondering, how can you assess that one works while the other doesn't if they, for example, are being offered at the same time?
Yeah.
Oh, well there, so notice, let me go back. To the extent that we can, we're testing them at different points in time. Now, I have to say that we'd love to do that all the time to be able to tell, but in many improvements, we've had multiple changes being tested simultaneously. And there was a time, a long time ago, when I started an improvement where we would do a total redesign thinking we know best or thinking the team knows best, and we would put it into like implementation, and we did get better results. But with that, what we didn't do is figure out what worked and what didn't work. So we were building a lot of waste because all of these changes are something that somebody has to do. Today we're being much more deliberate about not building in waste, not building in changes that we don't need to have.
I had a question too. Sorry to hold you up.
Please.
If you can go to the multicolor, the green and red
Which one?
boxes. The next slide. So there, the one question is always whether an intervention is delivered. So it can be
Whether an
an
intervention,
intervention is delivered. So it can be proposed and it can be funded, but it may not have been delivered. So I wondered if you were able to look at that. That's much harder to tell. It's much harder from an evaluation point of view to see whether, for example, it looked like medicine's delivery through a health volunteer didn't work very well. Well, why would that be? One of the reasons might be that the health volunteer just didn't do it.
sure.
And then the other question I had was that health cards were universally useful. And I don't, what are they? And
Well, a health card is like an ID card that has.
is it something that gives you access to services? Can you really not understand me through the?
No, I'm not hearing you well, please.
Is it something that gives you access to healthcare?
This is free care that they're receiving. So
You have to have a
but
health
But the
card?
idea, what the health card does is it has a summary and it has, some of the instructions and all of this on
It's
it.
like a patient retained medical record?
It's not a medical record though, it's just, a summary. It's a health card.
So it only has the blood pressure measurement and some
I'll
instructions?
be honest with you, I don't know what
Well,
a
all I'm
health card
saying is
has.
clearly that should be universal. It worked everywhere, it
Yeah.
should be universal, but I wasn't sure what it was.
You're right. So,
So the first question is, it's always difficult to tell whether an intervention is actually delivered. And the next question is, were you able to make some policy recommendations based on what we're, but maybe we're.
we can basically make suggestions to others who would like to do similar work based on this. There is an experience now that we can share. In some other activities, we've had multiple, places do something, and therefore we can say there's a body of knowledge. And what followed this was actually a qualitative study, which is still, being they're still analyzing it, and that will show a lot more details. Now, this is only talking about now what worked, what didn't work. How it worked, why it worked is another set of questions. This is where we get into the more interesting parts. Why did something not work? Why did it work? Why did it work in some places and not others? And a lot of, is there anything generalizable out of this, or is this all context specific? So I think, that would be a further level of evaluation. There is something which is being done now, being analyzed on this particular piece of work. But in other works in the past, we've had quite a lot of these, and we've compiled them in what we call knowledge products on improvement.
Somebody I worked with used to call that the type 3 error, when the intervention simply was not delivered.
Yeah,
So
and that happens, yes.
it would be a pity to call it, say that it didn't work.
So the reason why I paused here is is very deliberate. So here's the thing, we wrote this up and submitted it for publication. And the question that we got on it was very interesting. We got a question, they said, oh, you don't have enough baseline. And I'm like, why do we need baseline? Given what we're looking at, what is the issue? I mean, this is the whole data set. Anyway. So I realized, okay, we're probably dealing with people who don't do this work as much. And so what I did was, I asked them, yes, we do have more data, so we collected more baseline. And then I asked our research department, I said, could you actually plot it on what's called a control chart with upper and lower control limits, so that's plus minus 3 standard deviations in this particular case, and could you do it in phases? So they did the baseline, then they omitted, then we had the second COVID lockdown, which you can see there. Then we had the first sort of improvement data, then we had the third COVID lockdown, and we had the third, the second improvement data. And the control chart clearly shows that there's improvement there. But the other thing that our research department did was they actually ran t-tests. So they basically did a t-test between the first improvement data and the baseline, the second improvement data and the baseline, and the second improvement data and the first improvement data. And I thought, out of interest, we would like to see that. They all show that this is statistically significant. Of course, what it doesn't establish is, all the other parameters, but at least we know that something has happened, and the intervention, there was nothing else going on to our knowledge to be able to say that this is probably due to some external factor. Anyway, thought you might like to see this. Let me go on. I'm looking at the time and I'm thinking, I have a large number of slides like this. This is one that became very famous because Sir Liam Donaldson, when he was at the WHO, was showing it all over the place. This is early work we did in Niger. This is like 33 out of 36 health maternity centers in the country. This is aggregate data. Basically, it's the implementation of the active management of the third stage of labor to reduce postpartum hemorrhage. As you can see, when the blue line, the implementation went up, there was a serious reduction in postpartum hemorrhage. What was the issue here? The issue was not, and I'm going to rush through this one very quickly, it was not about is oxytocin available or not. It was not about do they know how to use it or not. The only issue was that the oxytocin is thermally unstable. It's in the fridge. In these health centers, there's only one fridge, which is in the pharmacy, which is locked at night. When the deliveries happen, they happen at night. And basically, the change that they tested was take a pre-filled syringe with oxytocin on an ice pack or in a cooler or something, and then it's available, ready for use by, and look at the results. They're staggering. And that's the type of thing where we know what works. Efficacy has been established. Effectiveness in that context needs to be addressed. Similar work, I actually had the Niger team go to Mali to help them with the top graph there is basically the same work. And this is now, Niger helping Mali with their postpartum hemorrhage work. And then after that, they, once we do the regular, normal deliveries, then we go into some of the other issues, like, for example, eclampsia, and you can see serious reductions there, as well as asphyxia. I'm going to run through these. This is work from, I'm just showing you a few things. This is work from Uganda. Similarly, improving antibiotic prescription practices in children. The gray areas are basically numbers of children who attend the clinics. And as you can see in the first one, basically pneumonia and antibiotics prescribed going up. Just simple cough that does not require antibiotics coming down sharply. And the last one on the bottom is children with diarrhea for whom antibiotics were prescribed, again, falling sharply. One of my favorites is this, and this was published in the AIDS journal. This is years ago, working basically to improve care for patients who have HIV and AIDS. And the idea was what constitutes good care, and we distilled it to three things. If somebody has HIV, then and AIDS, do they have their, is their status known? So there's a coverage gap. If their status is known, are they receiving the ARVs? That's our retention gap, which is actually what brought us to this work. This was the request, but we thought there's more to it. And then if somebody is retained on ARVs, are they doing well on this? And you can see the coverage gap, the retention gap, and the wellness gap. the blue line there are patients who either passed away or legitimately transferred out. That is, we know that they're receiving care elsewhere. The vertical line, the dotted vertical line, is where our funding ended and we had to stop providing assistance to them. But then we're still in the country and we're still able to communicate with them. They continue to provide us with the data afterwards. I've rushed through it very quickly, but just to give you an idea of the types of things that we do. Doing all this work, what have I learned? So the first thing that still comes up all the time is that we need to differentiate between measuring quality, assessing quality of care, and improving quality of care. These are two different things, and yes, improvement requires some level of understanding of the current situation, but it goes beyond that, and it goes to that work with people, working with them and through them in order to make a difference in the results that they get. We have a lot of terminology and methodology confusion in our field, and it basically comes from a lot of people putting a spin on certain methods and tools and things and relabeling them. I'll never forget, I was asked to go to a country where they needed our work. This was years ago, and I walked into the permanent secretary's office. He was expecting me, and when I sat down, I gave him my card, and he looked at it and he says, "Oh, Director Healthcare, USAID Healthcare Improvement Project." He goes, "Healthcare improvement, performance improvement, quality improvement, what's the difference?" I said, no, I'm really sorry that we're causing so much confusion. It really hit me hard that here, we're using all of these terms, and really all we're talking about is making healthcare better. And there's the science, and then there's the delivery of the science. And our focus is, of course, on the delivery of the science. That's what we're talking about, which does yield better results of that problem. One of the things that I've learned really well is simplicity. This is not work that I should be doing. It's work that I should be handing over to everybody who is providing care to their patients. Their first job is providing care. And what we're doing is we need to make it so simple that as they provide care, they can improve their care. And that's a really important concept. This is not a consultant's job. The consultant's job is to start it up, but if you're successful, then there's continuity, just like I showed you with the ARB work earlier. They continued without this, and I have many, many stories like these. That's really the secret of success. So it's really important that we make it as simple as possible for people to be able to pick it up and run with it. The next is, there are two areas where there's a lot of learning. First of all, we've made significant strides in scaling up, and this is a topic, if you're interested, I'm happy to talk about. But I still think we have a lot to learn about scaling up. And of course, a lot of the learning comes from actually doing the work and learning from the work. And even more important is this whole notion that in the global health arena is called institutionalization. How do you make it part of the fabric of everyday work? And that's really today we see islands of excellence, but it is not. We're nowhere near where we should be when it comes to making sure that this type of work, where a person not only does their work but also improves their work, is part of the fabric of the system that we're working on. I started to allude to the fact that how do we learn? It's not just did it work, did it not work? Why did it work? How did it work? Is it generalizable? Is it context specific? How do we establish, we cannot control for other factors. These types of changes in the delivery of care are part of the context, so they need to interact with the context as it is. So we can't actually be controlling. This is not an efficacy. I think this is an effectiveness. It has to work with that. How do we learn about that? And how do we establish that we've actually made a difference given this context? So that's we really started to move ahead with that now, and I think there's a lot more that we can learn doing that. And then, of course, with what's happening now, with this whole notion of health equity and how we can make sure that we're integrating health equity into everything that we do. And we've started to do that mainly by stratification of the outcomes and looking for different potential causes of inequity. And there's probably a lot more that we're, as we do this, we can discover more and more of this. The last thing I want to say is, I hope I've intrigued you with what I've presented. And if I did, and you're interested in learning more, I have put together a tutorial on how to improve healthcare. It's GPH 300, section 43. Basically, what it is a course that we run over Saturday and Sunday, where basically starts with a simulation exercise of a re-improvement project where you, as a group, walk through the improvement, actually doing it yourselves, and at every step there will be an introduction, a 10-minute introduction, so you don't need to know anything prior to coming to this. It's a 10-minute intro, and then you start to work with it, and you see what the team has done, and then we move step by step until we get the final result. So all the way from setting the aim for improvement, all the way to achieving the result, everything in between, and it's a hands-on simulation exercise. After which, you get to design a personal improvement project, something that you do every day, or that you can conduct within 2 to 3 weeks. You measure you set an aim, you measure the improvement, you make some changes, you see if it were, if they work or not, 2 or 3 changes. But it gives you the ability to test the use of these methods in real life. And I've done that myself in my personal work. And then we'll have a resume at on a Saturday, 3 weeks later. During those 3 weeks, there's office hours. The dates are April 1st and 2nd, and then there's virtual hours 6 to 7 p.m. On Wednesdays during those 3 weeks, and then Saturday, April 22nd is the last day where the presentations and final discussion happens. So if you're interested, you're most welcome to join and get a chance to sort of learn how to do this. I'll stop here and hand it over back to you, Marcia, for discussion questions.
Thank you. All right, good for questions. Jessica, do we have anything online? Okay. So let me start with the first one. So can you tell us a little bit about where in this process comes your work to deal with political will? Political will. So you can do great things. How do you make sure they are actually going to improve healthcare by implementing and sustaining whatever seems to work?
It's a great question. Political will is critical because one can make isolated improvements here and there in a system. But if the leadership is not bought in, it will remain at that level, if not even disappear. So part of this is the fact that as we embark on an improvement, the first thing that we do is we actually talk to the leadership in the system about what we're about to do. We are going to take their staff and work with them, and they are going to make changes in their everyday work. So these changes need to be agreed upon, approved. And so getting that initial understanding of here's what's about to happen, and then continually reporting on them as we do that. So in my, I usually make site visits. So as I'm making site visits, what I do is I start with the leadership because that's where I need to be. So let's say I'm going to a country, I will meet with, usually it's at the level of Director General, Deputy Minister, sometimes the Minister in a small country. Have that conversation first, and then go to the district where we're testing things and talk to the district health manager, and then we're in the facilities and working with the teams. On the way back, we report up in the same way. And visit after visit, doing the same thing. Basically, they're following, they know what's happening, and they become extremely interested. the request for national quality policies and infrastructure and human capacity building for that comes from them, but it can only come from them if the political will is garnered towards that. And that takes relationship building, it takes a lot of nurturing. And I have to say, we're not always successful. In some places we are, and others we're not.
Is there also a room to listen to the community in this chain that you
Absolutely.
mentioned?
Absolutely, actually, Marcia, this is really, I'm sorry I didn't talk about this a lot. So the AIDS work is all community-based. I mean, we're talking about, health centers, I mean, these are level 4 in Uganda, these are level 4 health centers, but there are primary care centers, and they do cater for communities. And so we're not just talking to the patients, we're also talking to the elders of the community and making sure that this happens. And so without them, it doesn't work.
Other questions?
I was curious about the story you told about the Pitocin that was unavailable because it was in the room, it was locked with a fridge that was inaccessible.
It's
And
funny.
so the solution was quite simple. And I think it's a reasonable question to ask, why wasn't it solved beforehand? And what are the dynamics that,
So I usually sort of don't rush through it because I get people to sort of engage in this. A lot of people will come up with a solution. Here's the thing. Imagine you're way out in the middle of nowhere with a health center and a midwife delivering at health center. That midwife has been trained and the oxytocin is available in the fridge. And of course, the pharmacist is a number of levels above her. And essentially what's happening is this, the woman comes at night, nobody is going to go knock on the pharmacist's door to wake them up. And so time and again, you come and say, why isn't this happening? Well, we don't have, the oxytocin is not, and then it's only when you form a team with the pharmacist and the midwife and this and that they start to realize, oh, okay, the problem is actually very simple. The solution to the problem is simple, but of course, here's the thing, as a pharmacist, he's not going to hand over the key to somebody else because he's responsible for everything that's there. So what they came up with, this idea of let's get a little cooler, let's put an ice pack, pre-filled syringe and an ice pack or something like that, that solved the problem. Now, this is a real story. This is not.
No, I believe it.
And it's life. And a number of, what's really interests me in this is that the solutions are usually so simple. It's no wonder, I don't know if you recall when Jim Kim was at the bank, he said, we've invested so much in the science of discovery, we haven't invested as much in the science of delivery. I think this is the issue. The issue is, yeah, we've got great things, and there's no reason why we should stop inventing. We need more and more. But if we continue to figure out things that work, but don't put them into practice for every patient who needs them every single time they're needed, why are we doing it? And so to me, this whole thing about delivery and adaptation to context is key to getting these types of results.
I guess I would see it a little differently. I would suggest to me that there's a software of implementation, not just the hardware. So not only that you have to have the materials, you have to have people who know how to use them, but you have to have power dynamics that enable their use as opposed to borrowing them. And those are not things that we talk that much. Behavioral economists talk about it, but we don't really talk about it that much in public health.
You're right. I mean, there are power dynamics. That's why a nurse can sit or a midwife can sit there, not have access to the oxytocin, and she's not able to say anything.
Right. Okay.
The power dynamics are very powerful in these cases. But this type of, when you put everybody on the team, we're trying to deliver care to patients. I mean, these are the red line that I showed. The postpartum hemorrhage, and that carries half of them will not make it.
That's right.
And especially in a country like that. I mean, we're talking about mothers dying. Yeah, that's what we're talking about. Yet the power dynamics stop something like this from happening.
You were going to say something?
No, I was just gonna say this whole issue about sometimes what we need is not new technologies, it's just to get things right, although some of the funders only want new
Technology, or they wanna,
Let's
you
not
know,
get
do
started into that.
inventories or track supply, you know, look at
Yeah.
supply chains or.
Exactly.
And there are these other issues of trust and power that can be just as.
Yes, please.
Thank you very much for your talk. My first question is logistic. Is it possible to attend the tutorial online? And the second one, or
I haven't thought about that, but it would change the dynamics a little bit. If you're not able to attend in person, sure.
Alright, thank you. And the other one is maybe a bit like looking into the future. What is your vision on maybe how we can all engage in this field and how we can really scale it up? I know that's a big question, but I guess that's a personal struggle that I'm feeling like where to start and just to start in one small environment or how to kind of, translate it into something
So
bigger.
the reason why I'm here is exactly this, because I feel that this is so important. I have dedicated my career to it, and you know, there's been a lot of successes. I can show you graph after graph of results, but these are all drops in the bucket unless we get the whole community of, you know, health experts and healthcare delivery and leadership involved in this. And so to me, engaging is key. Now, I have a colleague who's now retired. He at one point when they ranked health systems, Sweden was ranked #1, and Jönköping County in Sweden was ranked the #1 county. Sven-Olof Karlsson was the head of that county. He had a saying, he said, your job is not just to do your job, but to improve your job. That was his thing. He would say that every time he spoke. It's amazing. I mean, unless we get people to think that way and operate that way, it's very difficult. So where would I start? We're starting right now. And where would we? I hope everybody learns to do this and we get to do it everywhere in all of our. There's been a lot of progress. I don't want to make it, you know, I mean, I started this years ago and I see the progress and it's pretty amazing. Actually, on March, I think 7th, when do we have the careers trajectory? March 3rd. March 3rd, there's a careers trajectory webinar. I have the Director General of the Ministry of Health of Uganda. He spearheaded the improvement prior to becoming Director General. Still continues to be public. So you hear from somebody who's in the field, in the trenches doing this work.
Yeah, and just to reinforce, career trajectory is something we started. Rashad is leading this, and it's a chance to listen from people that, you know, in the past were exactly in the position where our students are now. Lots of questions. How do I start? Where do I go? And we had our first edition about 2 weeks ago, a week and a half ago. It was really nice. You were there, right? No, okay, there were a few students there, not as many as I would hope, but it was really a great discussion. And one of the MPH students that was there, she's a pediatrician. One of the guest speakers was a pediatrician, and it was nice because the speaker mentioned questions she had, which were exactly the same questions the student was having. So it's a chance for you to see the different trajectories you can take after you graduate. I hope for the second session, we're gonna have more students participating because it's
March.
really,
March 3rd.
March 3rd, yeah, it's always a Friday lunchtime. It was really good, and I think it's good to listen from people that were exactly in the point that you all are right now. And, you know, there's always some wisdom to learn. Do we have questions online, Jessica?
No, there's none right now.
Okay. Other questions, folks?
Let me thank you all very much
Okay,
for
thank you.
joining and thank you
Appreciate it.
everyone. Thank you.